Hello friends, this is a 70-year-old patient with intumescent hypermature cataract in his right eye. Patient also has pseudoexfoliation. The surgery is being done under subtenuous anesthesia. This case was challenging for 3 reasons. First was the presence of pseudoexfoliation, which implied possibility of loose zonules. Second, rhexis was going to be a challenge in a hypermature Morgagnian cataract. And finally, Morgagnian cataracts have free floating nucleus. This would also be challenging during nucleus management. I had a few plans up my mind to manage the initial steps in this case. First was to stain the capsule with trypan blue and then make a tiny opening in the anterior capsule. Then decompress or empty the bag of the liquefied cortex. Third was to complete the capsulorhexis. Let's see whether the surgery goes according to the plan. The side ports are made. The staining of the anterocapsule is done under air. The dye is removed. I am using the soft shell technique here. I begin by injecting a dispersive OVD, then I inject the cohesive OVD. A tiny nick is made in the anterocapsule. Fluid liquefied cortex starts to leak from the opening made in the anterocapsule. Using the bimanual irrigation aspiration cannula with low infusion pressure, the liquid cortex is gently aspirated. Quite a significant amount of fluid cortex is aspirated. Though this is going to be time consuming, it is critical to remove the milky liquid as it hampers the visibility while doing the capsulorhexis. The bag is finally emptied of the liquefied cortex. Now that the visibility has improved, I begin the rhexis with forceps from the initial nick made in the capsule. The rhexis is around 4.5 mm in size, a little smaller than what I intended. The nucleus is also small, and I go ahead with the nucleus management. The nucleus is always dense in the central zone. My approach here is to debulk the cataract in the center and then get a lateral separation. I begin in the sculpt mode. The nucleus is free floating, and during sculpting, the nucleus has a tendency to move sideways and slip away from the phaco tip. To overcome this, I using the chopper to gently grip the nucleus and trenching is done. The central dense core is debulked and lateral separation is achieved. I am using a sharp chopper, so I am careful here not to be in close proximity of the rhexis margin. Vertical chopping of the heminucleus is done. The chopping of the heminucleus is carefully done in a safe zone away from the rhexis. I need to confirm the fragments are free. I inject viscoelastic. Using 2 Sinskis, I gently separate the fragments. Each of the fragments are emulsified. The second heminucleus still has a sticky posterior plate. Carefully, the posterior plate is reversed and trenched. Reverse trenching achieves separation of the posterior plate. Now the fragments are completely separated and emulsified. The residual cortex is removed with bimanual irrigation aspiration. Planned IOL is implanted in the bag. Residual cortex is aspirated. Just when I was about to close the case, I went with my aspiration cannula near the superior side port to aspirate some remaining cortical fibers. The cannula had inadvertently engaged the equatorial bag and pulled the bag with evident zonular dehiscence. At this point, I decided to place a CTR as I wanted long-term stability of the IOL. Again, I inject OVD in the antechamber. The capsular tension ring is introduced in such a way that I could rotate it in a clockwise direction so as to support the area of zonular weakness. Injectable CTR would also work well in these situations. So at the end, viscoelastic was removed and everything went off well with this case. So the take-home message is nucleus management in a small rhexis in a Morgagnian cataract is quite challenging. In this particular case, I have used a sharp chopper to deal with the nucleus, but it is mandatory to carry out the vertical chopping in the safe zone as there is always a risk of damaging the rhexis or the anterior capsule. Reverse trenching of a sticky adherent posterior plate can be a safe option in dealing with hard nucleus with tough posterior plate. Hope this was helpful. Thank you.